Sir, over to you.
Thank you. Good afternoon, doctors. Welcome to this webinar on the role of Oseltamivir in fluvial management. This webinar is brought to you by Heathrow Healthcare. Heathrow Healthcare, our journey began in 1993. We have 30 years of excellence and 36 state-of-art manufacturing facilities. We have 300 plus products in portfolio and presence in 126 plus countries. We have 21,000 employees globally, and we are amongst the largest manufacturers of ARV, APIs, and FDFs in the world. We have Asia's largest API manufacturing facility at SEZ complex, Visakhapatnam, Andhra Pradesh. Heathrow Healthcare, a 360-degree solution provider, striving to fulfill unmet healthcare needs, reaching to customers across India with wide product range encompassing multiple specialties, pioneering in quality and innovation, and we have distinction of bringing 4 biosimilar products to market within 5 years of initiation. During COVID-19 pandemic era, Heathrow Healthcare, the pioneers in antivirals, offered Oseltamivir, Favipiravir, and Remdesivir to the patients, because of which they received an award of Pharma Excellence in August 2020 for COVID drugs. Today's webinar, Role of Oseltamivir in Flu Management, we have got Dr. Pramod Jog with us. Welcome, sir. Dr. Anil MU and Dr. Somashekar AR. Welcome, sir. Dr. Pramod Jog is Professor of Pediatrics, D.Y. Patil Medical College, Pune. Sir is President IIP 2016, Steering Committee member GAV CSO 2016-19, Chairman Mini Recipe Module IIP, author of book Cophology. Professor Dr. Somashekar AR, is Professor Ramaya Medical College, Pediatric Pulmonologist and Adolescent Care Specialist, President IIP State Respiratory Chapter 2015-16, Treasurer IIP Allergy Chapter 2015, IIP State Allergy Chapter, Joint Secretary IIP Bangalore 2016, Secretary AHA 2016-17, EB Central IIP Respiratory Chapter, EB Central IIP 2015-2017, Secretary IIP State Allergy Chapter 2021, Chief Editor Pulmoscan, Executive Editor Journal of Pediatric Pulmonology, EB National Respiratory Chapter 2023, Secretary Environment Chapter of Child Health Group IIP 2023-24, President IIP Bengaluru BPS 2024. Welcome, Dr. Somashekar. Dr. Anil MU, sir, is MBBS MD Pediatrics Fellowship in Pediatric Critical Care, Diploma in Allergy and Asthma. This sir is Lead Consultant, Pediatric and Pediatric Critical Care from Sparsh Hospital, Bengaluru. Welcome, Dr. Anil. And with this brief introduction, I'll hand over the session to Dr. Pramod Jog. Over to you, sir.
Okay. Right. Can you see my screen and can you hear me?
Yes, sir.
Okay.
Yes.
Thank you. Thank you. Okay, very good. Okay. So, my dear friends, today we have to discuss a topic related to influenza and the management. Everyone is aware that the monsoon is in full swing, and lot many cases of viral infections are crowding our OPDs, and either it is the influenza virus or respiratory syncytial virus, which is producing the acute respiratory infections. And in addition, of course, we have mosquito-borne illnesses like dengue. And we have to discuss the management of influenza with particular reference to the use of oseltamivir in influenza management. And I am glad to have two influencers, our pediatric colleagues, Dr. Anil and Dr. Somashekar. And we need to understand that every influenza virus has a particular nomenclature. Now, as IIP president of 2016, I always say that I was the presidential strain of 2016. And if you see, the nomenclature of the influenza virus includes the place of origin, the month and the year of isolation, etc. So you can see that the name of influenza virus has a very, very specific way of nomenclature. So basically, when it is monsoon, we all know that the farmers are very happy, the frogs are very happy, the doctors are happy because the season is in full swing, and of course, the pharma is happy because the sales are in full swing. But whenever someone says it's viral, I remember recently there was a small little girl who came to the OPD with a doll, and while I was examining this small little girl, the girl was speaking to her doll and telling her, don't worry, it's viral, it's viral. So even a small little girl knew that, viral infections are very, very common. And you must have witnessed so many parents asking you, sir, I hope there is nothing to worry. It's all viral, no? So many times I say, yes, it's viral. But then earlier, I was not worried when I used to say that it's viral. But now the days have changed, and after particularly the pandemics of H1N1 and COVID-19, when someone says viral, I am really not always very happy, but I am little scared inside my mind whether this particular viral infection would take some other turn. Dr. Somashekar, I just wanted to ask you whether the incidence of viral infections has increased over last few years, and what do you think are the possible reasons for all this?
The reason we can't figure out as such, but the thing is that past 2 3 months in Bangalore as such, I'm sure in Pune also, the rising trend of viral infections there, and of course it is not only the flu, influenza. We do get cases of RSV, adenovirus. All these cases are difficult to differentiate each other, and pockets of dengue fever also is there. If you take overall picturization, more all the three have high fever. Maybe prodromal symptoms are more with adenovirus like conjunctivitis, and when it comes to RSV, it is of more of bronchiolitis like picture. But to suspect the influenza like illness, it is like after there'll be majority 90% is a mild disease. By third day, if it may progress to the severe one, that we should be having high index of suspicion. Of course, past 2 3 years it has raised, but with this epidemic this season, it was more compared to the previous.
Yeah, I agree with you. And of course, after this COVID-19, children during that particular pandemic were all indoors, and hardly anyone developed any immunity against some of these viruses. So I remember when the pandemic was on decline in the latter half of 2022, different viruses, they started making a surge. And I remember respiratory syncytial virus, then adenovirus, then hand foot mouth disease. And in some parts of our country where measles immunization was on the lower side, even measles came up in a large way. And I'm seeing that even the older children are getting affected, with these viral infections. So when I came across a 3-year-old boy with fever, cold, cough, and progressive breathlessness recently, with tachypnea and hypoxia, and a X-ray picture like ARDS. This child was admitted to PICU, was ventilated, received Oseltamivir, and turned out to be H3N2 positive. He was ventilated for 3 days. He improved, although. And then everybody was thinking as to whether, early Oseltamivir would have helped this child. So, particularly in a previously healthy child presenting with cough, cold, and fever, progressing over 3 days, whether the treating clinician could have prevented this progression by putting this child on oseltamivir upfront, particularly in the flu season. And that's why there are certain areas where there is some confusion, and that's why I have just put it as conclusion, because these are some issues related to influenza, related to the facts whether this is bacterial or viral, whether this respiratory infection that I am facing and the virus which I am facing is rhinovirus, adenovirus, influenza, parainfluenza, or something else. If it is influenza, whether it is H1N1 or H3N2 or some type B, and whether I should start oseltamivir upfront in this child, and this is only whether I can play safe so that the child doesn't progress to any serious complication. So we all know that in monsoon there are all those respiratory illnesses, presenting with a great challenge. And in India, the incidence of flu and related deaths are increasing alarmingly. We all are aware that influenza A, B, and C are the three different types of influenza viruses, of which influenza A is the one which is the cause of frequent epidemics. because of minor antigenic variation, and periodic pandemics due to major antigenic variations. And influenza B viruses infect only humans and cause local epidemics. This influenza virus particularly has two important glycoproteins on the outer surface, which are known as HA and NA, hemagglutinin and neuraminidase. And hemagglutinin are the ones which are responsible for attachment of the virus to the respiratory epithelial cell. Once the virus gets attached, the RNA of this virus enters into the respiratory epithelial cell and multiplies. And the other glycoprotein, neuraminidase, helps these virions which have collected on the, inner part of this respiratory epithelial cell wall and which are waiting to go outside. So neuraminidase is like a molecular scissors. So it allows, these viral particles, the virions, to exit and then infect other respiratory epithelial cells and somehow helping the spread of the virus. And oseltamivir, the molecule that we are going to discuss today, is the one which exactly acts as a neuraminidase inhibitor. So it's important that we are aware of these two glycoproteins. And HA is an antigen, particularly against which, the vaccines that we give to children, they give some immunity. And there have been four major global pandemics till now: 1919, 1957, 1968, and 2009. And every time the structure of this H and N changes. And whenever a new pandemic sets in the world, the earlier strain which is circulating gets replaced. Okay, so right now it is the 2009 strain which has replaced, the earlier existing strain in the atmosphere. Okay, so Dr. Anil, what is your impression about the current epidemiology and the circulating strains of influenza viruses, which are affecting the pediatric population in our country? Maybe you can have a reference to the city, Bangalore,
Please.
where you are
Yes, sir.
practicing. Yeah.
Yes, sir. Thank you, sir. As sir has been telling, since the onset of monsoon over the last, say, 1 to 1.5 months, we also have been facing this epidemic of flu-like illness, and more so when we start swabbing them, that is when we get to know. Probably previously we didn't know, like the PCR facilities were not there, and thanks to COVID, now a lot of laboratories have come up with the PCR technology, and they're able to give us the reports very, like, probably in 12 hours or 24 hours we'll have the reports. And what we are seeing, especially when we do a nasal swab or a nasopharyngeal secretion or a nasal swab, we do get the reports in 12 to 24 hours. And majority of this season has been H3N2 variety over here in Bangalore. Also H1N1, yes, we do see H1N1 variety also, but the numbers are very less. But majority, I would say 90% of these influenza A subtypes, it's been coming as H3N2. Earlier, as sir has been telling, neuraminidase and also hemagglutinin, based on this, these viruses are categorized. H2 variety we are not seeing off late. And also the named lineages like Victoria, Yamagata, these kind of lineages in the influenza B variety also we have not been seeing in this season. Over the last, say, almost, say, 1 year, we have not seen these viruses. So there has been a push from the WHO side also, looking, because they keep monitoring the current ongoing strains of these viruses. So the current push is to come back to a trivalent. We have been using a tetravalent vaccine, and most probably from the next year will be, like, there are views for and against both of it, but most probably, because these viruses have not been detected, going forward we'll be using a trivalent vaccine probably from the next year. So H3N2 is the answer for your question, sir. That is what's been troubling us in Bangalore.
Yeah, yeah. And even in Pune, where I practice, similar situation exists. And I'm glad that you told our colleagues that the new vaccine is likely to be trivalent and may not contain this one of these Victoria B lineages. So one knows that flu is a highly contagious illness, and it can spread up to about 5 to 6 feet, and these viruses spread mainly by, major droplets when people cough or sneeze or talk. And it can also spread through surfaces when someone shakes the hands or, sneezes or coughs in the handkerchief or, puts the hand on the surface. So there are different ways of transmission to the people nearby. And Dr. Somashekar, you have been seeing so many cases of influenza now, and I would like to know as to what are the various clinical scenarios with which influenza virus can present in the pediatric population.
If for of course there is a category A, B, C is there. Before that, majority in the population it's a mild illness. Okay, like acute onset of fever, cold, cough, sore throat, rhinorrhea, and when it comes to flu-like illness, they'll have extra symptoms like GI symptoms, like they'll have vomiting, diarrhea, abdominal pain may be there, or they're associated with severe body pain. That is there, and it can be there in other symptoms also. But if the patient is stable for 2-3 days and worsening symptoms, that gives a clue that you do suspect about flu-like illness and do whatever the investigation related or have a high letter of suspicion. That is one thing. And also these children are prone for, they'll if they got other comorbid condition, there one they deteriorate very fast, like in a nephrotic syndrome or immunocompromised state. Of course, is diffuse scenarios. Last time Dr. Sanil was telling about a case of encephalopathy, which he recently treated, and we had a case of nephrotic syndrome deteriorated very fast, and it was in shock. So these kind of varied picture also is there, and majority it's a self-limiting, but high index of suspicion is very much required. And when it is compromised state, be careful. That's what I mean.
Yeah, that's great. And Dr. Anil, do you have any other experience about these presentations?
Sir, majority of these presentations have been more like a OPD kind of presentation, what we would see as a common cold, cough, fever, myalgia, which comes. And then the more severe varieties who present with very high grade fever, sore throat, probably these are the ones who are requiring hospitalization. Like those are the moderately sick to a severely sick person who is requiring, only they require hospitalization. But majority of the presentations have been a mild self-limiting kind of illness is what we are seeing. But we should have our antennas up for the category B and category C symptoms where they need immediate hospitalization.
Sure. So just to recapitulate, I would say that, influenza-like illnesses come to our OPDs quite often, but influenza is the father of all those influenza-like illnesses. And whenever you come across a child who has headache, severe body pain, weakness, and even an older child, being brought to the OPD, lifted by his parents, then many times I suspect that this is likely to be influenza, particularly in the influenza season. And these are all systemic manifestations. Viruses like rhinovirus and others, they are more localized viruses, and they do not produce all these systemic symptoms like headache and high fever and muscle pain and all. So when you see such a child, then you should always suspect influenza. And as our colleagues have already told you, it can present with some complications like febrile seizures or encephalopathy. And being a viral illness, basically it's a disseminated disease, so we can expect vomiting and diarrhea in a subset of children suffering from influenza. But the most important is influenza is basically an illness of children, and from children it spreads to adults. We have seen that in COVID we had adults spreading the disease from adults to children, and that's why in influenza vaccination is primarily starting from the pediatric age group. In COVID we had mainly the adults being vaccinated, and then subsequently we started discussing about vaccination of adolescents and children. So we have basically so many influenza-like illnesses, H1N1, severe acute respiratory infections, COVID-19, all those respiratory viruses presenting in one way or the other with similarity of presenting features. However, it is important that you inform the parents about such emergency warning signs. So, Dr. Anil, now that you are in the intensive care unit, what are the various warning signs related to flu that you inform the parents when they come to you in the beginning?
So the most important or the telltale sign is the lethargy of the child, inability to feed. Child becomes very lethargic. Even the interfebrile period, child is not active and playful, becomes very lethargic. Child is unable to feed, starts having very severe sore throat and body pain, myalgia. Like sir told, the parents will have to lift the child up and get to the OPD. This is the kind of presentation that we see. Also, if we go systemic wise, we look at the respiratory system, They may have initially to start with, they may start with a non-productive cough, then they go on to develop a fast breathing or a tachypnea, chest retractions, cyanosis, inability to feed, and if they check the saturations, it may become low, or CNS complications they may have because of the high fever. So sometimes febrile seizures, we have seen it's become very common with this flu-like illness. They may throw a febrile seizure, or they may progress on to go on to develop some CNS complications like encephalopathy. These kind of complications also we have seen. And as we know, it's a multisystemic illness. Any viral illness involves the multisystem. So they can have some effect on the liver, on the kidneys, and if it left untreated, they'll go on to develop a multisystemic illness. So when we are treating a flu, like 90% of our OPD patients who come with fever, cold, cough, we always ask the parents to watch for any lethargy, inability to feed, tachypnea, or overall uneasy feeling, unwell child. If it is there, please come back to us in the next 24-48 hours. We do warn them.
Right, right. That's very good. So usually in my OPD, what I do is, as Dr. Anil said, that in the beginning, most of these children who come to us have those typical respiratory symptoms, and majority of them are mild. But usually I tell them to come back or report after 3 to 4 days, because we know that it's likely to be a biphasic illness in some of these children. And then that second phase, could be the one where the child might be serious, and all those warning signs, usually we tell the parents that in case if these things happen, they have to report. But even otherwise, I usually tell them that if you come for a follow-up, I usually tell them that I won't charge you for the follow-up charges. That gives a bit of a reassurance. Some of them are worried about the, payments and other things. So I usually tell them that you come. Usually, I believe that, the second visit of a patient in the initial first week is basically for my learning. When the patient comes to me, usually I am learning whether this child is worsening, and it's also important that we know that the child is not worsening. So it's very important that you inform the parents about these warning signs, because on day 1 and 2 these signs or these some of these presenting features may not be there. Okay. And the complications of flu, I usually would like to put them with the alphabet A, like complicating into pneumonia or ARDS or acute otitis media or absenteeism from the school or antibiotic abuse. Because in the beginning, when a pediatrician is unable to differentiate viral from bacterial, then one is likely to tend to prescribe antibiotics. And of course, we'll be discussing in the course of our discussion today as to what are the places where you could use antibiotics rationally. So Dr. Somashekar, now we have some categories of influenza depending on the severity, like category A, B, and C. And the management of influenza basically is divided depending on the categories. I will just tell our colleagues about these antivirals, and then we'll go to the management. The virus, as I told you, has hemagglutinin and neuraminidase. And neuraminidase is the one which is responsible for release of the virions to the other respiratory cells. So if this release is blocked, the spread is blocked. So this oseltamivir, the neuraminidase inhibitor, blocks the viral neuraminidase enzyme, which is critical in releasing the virions from the infected host cells. There is another group called adamantanes, where there are medicines like amantadine, rimantadine, which interfere with hydrogen ion channel activity of the influenza A virus, blocking the entry into the host cell. And oseltamivir is a potent and a selective inhibitor of the neuraminidase enzyme of the influenza viruses A and B, and it's the prodrug which is converted to the active form oseltamivir carboxylate in the liver, and it inhibits the influenza virus replication and pathogenicity and prevents further spread of infection. This is a diagrammatic representation of the same thing, where you can see that there is a virion, and there is release of the new virions to other respiratory epithelial cells, but oseltamivir is the one which blocks this particular release. This oseltamivir was the first oral neuraminidase inhibitor, and now is approved in more than 100 countries, and bodies like CDC and American Academy of Pediatrics have approved this drug. So, Dr. Somashekar, what are the different categories for treatment, and what are the current recommendations for the use of oseltamivir in the OPD and the IPD basis?
Coming to the clear cut, of course, mentioned about already about the category A patients, they'll have common what is the current epidemic is going on with mild fever, cough, all those things. But category B is the one where you have high risk and severe symptom may be there. They'll be added with category A symptoms and less than 5 years old children, or especially less than 2 years, and with other comorbid condition we can think. The question is when it comes to OPD management, there's no role of starting any oseltamivir at this because you categorize properly, treat. I have a high index of suspicion. Ask them for the, as you said, follow-up is important. Within 3 days, you review them and take a call on that. But when it comes to the admitted patient, what you should do is just routine follow-up is important, and you should monitor in such a way that if it's a progressive symptom and the expected outcome is not there within 2 to 3 days, that is the time we should send for the swab and start the oseltamivir. Here maybe the symptom may be worsened or maybe the clinical deterioration may be there. Whatever it is, should have a within 3 days. You should reevaluate once again and start the medication.
Right. So this is only the tabulation of what Dr. Somashekar said, that for the category A, there is only home isolation, bed rest, plenty of fluids, and paracetamol for fever. But one should avoid aspirin for fever because we know that aspirin can precipitate Reye syndrome in children with influenza. Of course, this has become rare now, but when we were residents, we could see Reye syndrome to a greater extent. And of course, category B, where there is further worsening, and the respiratory rate is increasing, and this is the place where you can send a swab and also probably start antivirals, but within 48 hours. And category C, where the child further becomes serious with hypoxia and some other complications, and here testing is necessary, hospital admission is necessary, antivirals are necessary, and close monitoring is necessary. So this categorization will help us in many conflicting situations, as to whether we should start oseltamivir or no, whether we should wait, and we will see during the course of discussion in relation to certain cases. As regards the dosages of oseltamivir, the added dose is 75 milligrams twice daily, particularly for the therapy of influenza. And in children, it depends on the weight bands. So children less than 15 kg receive 60 milligrams per day. Between 15 and 23 kg, the child receives 90 milligrams. 23 to 40 kg, about 120 milligrams. And beyond 40, it is 150 milligrams. And this total dose is divided into two parts, morning and evening. And in case if at all you have to give oseltamivir for chemoprophylaxis of contacts in the family who are at high risk, then the same dose is given once daily. That means for a child who is between 15 and 23 kg, it's 90 mg per day. That is the total dose, but we give it into two doses. But the prophylactic dose is 45 milligrams once daily. And likewise, you can see in this table the different dosages. In infants who are less than 1 year, the dose is 3 milligrams per kg. And in infancy, chemoprophylaxis is usually not recommended, though the therapeutic dose is 3 milligram per kg in infants from 2 weeks onwards up to 1 year of age. We have the syrup of oseltamivir, which contains 12 milligrams per ml, and you can calculate the dose accordingly. Dr. Anil, now that we know most of the things about the management and the categorization and about oseltamivir, how does early initiation of oseltamivir influence the clinical outcomes, particularly the duration of illness, the progression to severity, and the complication rates? And we would also like to know, in case if the patient comes on day 4 or 5 with respiratory infection, with distress, and who is H1N1 positive, can we give oseltamivir?
Oseltamivir is a wonderful drug. I think as and when we have been using it, we have gained confidence over it, and it's quite a safe drug. Like Sir told, it's a prodrug which gets converted into its active form, and it acts on the neuraminidase inhibitor. So the way it acts is it prevents the release of these virions, which is affecting the host cell, from affecting the other cells, Basically, it is stopping the spread of these virions from one cell to the other. So in effect, in the long term, when we look at it, what is happening, it reduces the duration of this flu by around 1 to 2 days. So someone who has gone through this severe fever, body pain, headache will vouch for it. Even that reduction of 1 to 2 days, it's a great benefit. And more so, it is preventing from other complications or a further progression. It is halting. So the literature tells us if it is instituted before 48 hours, the benefits are the best if it is instituted within 48 hours. So in a season of epidemic, when we are getting these cases, someone else in the family has got very typical flu-like symptoms or they've been diagnosed with a swab, then we don't have hesitation. We go ahead and start them on treatment dose within 48 hours. So only when there is little bit of doubt or they're in category B, C, we are waiting for a swab report, we go ahead and start them on empirical dosages also. So by doing so, we are making sure that we are reducing the duration of illness, so the recovery is much faster and also the progression. And the next question is, how late can we start? So since we are a referral unit, we do get cases as late as day 4, day 5 also. Like they've been treated, usually they go to a pediatrician on day 1, day 2, symptomatically managed. Third day, they are started on probably oral amoxiclav. They're started. Day 4, day 5, if they're not improving and worsening, they're referred to our hospital. So they, by the time they come, they already have a lower respiratory tract infection or a multisystemic illness. And even then, as late as day 4 to day 5, we do start them on empirical oseltamivir awaiting the swab, or even if the swab is positive, we start them even on day 4 to day 5 to extend the benefits, because it definitely improves the duration of illness. It reduces the duration of illness, and also it prevents, help us in preventing complication. So hence, it can be best effect is within 48 hours, but it can be started as late as 4 to 5 days as well. And if they're sick, yes, even much later, if they're immunocompromised, if they're sick, undergoing a someone is on ventilator, even much later than 4 to 5 days also, we do start.
Yeah, that's great. And we have literature which supports whatever you said. And even in Pune, we had in an institute similar trials where even the administration of oseltamivir, even on day 7 or 8, had helped children in particularly relation to reduction in the mortality. So in general, there are many benefits of the empiric and the early use of oseltamivir, and particularly in patients with influenza, it reduces the antibiotic usage, also reduces the lower respiratory tract complications and the rate of hospitalization. And it's important to note that these advantages are not only in children but also in adults. And that's why WHO has recommended empiric therapy strongly. And the treatment should be started as soon as possible. And the laboratory confirmation of the influenza virus is not necessary, and negative laboratory test for H1N1 does not exclude the diagnosis in all the patients. At this juncture, let me ask Dr. Anil again about his experience about this, PCR test which is done on the nasopharyngeal swab related to influenza, and how good is it as regards the specificity and sensitivity?
Yes, sir. After COVID, it's opened up lots of avenues for these PCR and molecular testing laboratories have come up in a big way. And it is helping us also in getting these diagnoses. Earlier, we would have just classified them as ILI, and strictly according to the protocol, we'd have treated them category A, B, and C. And even then, probably to get a H1N1 test done in 2009 pandemic, we used to wait for good 48 hours or even little more than that. While being on empiric oseltamivir, we had to wait for that much duration. But these days, we get these reports very quick and fast. And when I looked up the sensitivity and specificity, that is, sensitivity is anybody who has a disease will be flagged as positive. Specificity is anyone who doesn't have a disease will be flagged as negative. So the latest generation of PCR testing have got a very good sensitivity and specificity, probably more than 90%. I would say 90 to 95%. It scores both on sensitivity and specificity. It scores more than 90%. But it also depends on multitude of factors, like how well the swab is being collected. If it's a very superficial sampling that is happening from the anterior nasopharynx or front of the nose, probably the pickup rate will be much lesser and the sensitivity will drop down to as low as 60%. So in a combined value, what WHO says is these tests are anywhere sensitive between 60 to 90% sensitivity is what they say, but the specificity value is more than 95%. So the negative laboratory testing of H1N1, when we don't have any alternative diagnosis, clinically, our clinical acumen is strongly in favor of a flu-like illness, but the test comes negative, it could still be a flu-like illness where we may have to continue whatever empirically we would have started. We need to continue it and finish the full 5 days treatment course of it in such situations. And also, I would like to bring about now the panels we are doing. It's a multiplex panel. So nowadays we do get different panels where we test only for the flu panel. That's the influenza group of viruses. We can ask for only influenza A, influenza B, H1N1, H3N2. Only these viruses are tested. So cutting down the cost difference will be there. And we can add the extended panel. So some laboratories add adenovirus to it. Some laboratories add a RSV virus also to it and do it as a panel. So even these panels have got an excellent specificity and picks up the virus in, I would say, more than 90% of the times. Our clinical, whatever doubts we have or whatever suspicion we have, usually it comes up positive in these panels.
Yeah, that's very good. And I'm glad that you informed our audience about all the details about the test. Now, Dr. Somashekar, the question is that, some of our colleagues who are a little bit away from major cities like Bangalore and all, they might be, worried as to how to get this test done. And whether, this empiric therapy they can, resort to. So what is your opinion where, these tests are not available? What best can they do?
The majority in two-tier cities, we don't get these tests. If in corporate cities, that's a different story. But
Okay.
question is, there is better to avoid this empirical. Of course, we do give empirically, but let us not, empirically we should be properly defined. If you have high index of suspicion, progressive disease, and similar like illness with lot of comorbid condition like like cardiac issues, immunocompromised, diabetes, or a case of asthma, chronic persistent asthma, there is a role of this empiric therapy. Apart from that, if a patient without any comorbid condition progressing towards the complication, please give the empiric therapy whether you have facilities for the testing or not. Otherwise, just for the empiric state or just for our and his worries, you should not give the empirical treatment.
Yeah, and I understand that the categorization that we have into A, B, and C will probably help our colleagues, particularly in the situation where influenza is rampant in the atmosphere. So with this, there is one child, Viru, who has fever for 3 days with cold cough, and he is on metered dose inhaler since 4 months. He is well controlled on that. But after the symptomatic therapy given for 3 days for this present illness, he comes back simply after an interval of about a day, again with fever, though he has been active in between. And this obviously becomes a case of recurrent viral upper respiratory infection. As I said earlier, they have become more frequent. They are occurring at a shorter interval. And quite a few times, the parents, they demand antibiotics, and then it's very difficult to convince them as to antibiotics are not required for viral respiratory infections, but they are worried about the recurrence of these problems. So, Dr. Anil, how would you counsel, the parents about, recurrences of these viral infections in these situations?
Yes, sir. This is a very, very common situation we come across. I think giving them 2 extra minutes for this family and to sit down with them and counseling them will go a long way in counseling them. As you told, sir, the child has been active and playful in the interfebrile illness, and it's a minor illness. There are no red flags over here. The child has been having this fever, cold cough on and off, and it has some V's for which the child has been on MDI. It is well controlled, and if the child is active in between the fever, probably is just caught on to one more viral. This is a typical category A kind of patients where we just have to treat it symptomatically. And at the same time, we need to address the parents' anxieties. Probably we sit down and we tell them that this is a typical childhood, that the child is going through these recurrent virals. And we will assure them, if at all they're asking for antibiotic, we'll tell them, explain them. All these markers, this is an acute febrile illness, little bit of mucosal involvement is there. Chest is very clear when I am auscultating. I spend 1 minute to auscultate the child and reassure them that the chest is very clear. I've examined the throat clearly in front of them. In fact, show them the throat and tell them, see, the throat is very clear. The ears also, I check the ears and tell them that the ears are clear and the child is active, playful. So I will reassure them, telling that this is just one more viral illness. We don't have to worry. And if at all any concerns are there, we'll revisit in the next 24, 48 hours. If any of the red flags are there, please do come back. Then we will see if really the child requires antibiotics, we'll definitely go for it. So spending that 1 or 2 extra minutes and explaining them helps in such a situation.
Sure, that's very good. And I'm sure in addition to whatever you said, this demonstration of the growth charts which are showing an upward trend as regards the weight and the height of that child would
Yes.
also reassure the parents that there is nothing major in that particular child. And Dr. Somashekar, do you have any additional points which you could use for counseling the parents?
Just tell about the red flag signs also. If you
Okay.
don't start antibiotics or anti-flu also, just tell about if the patient is review after 3 days and to visit the AR and wherever, if the patient has decreased activity, poor feeding and vomiting, dehydration, just make a note of and ask them for come to after 3 days to re-evaluate once again with the current scenario.
Right. And it is important that many of us are aware of a bit of a clinical differentiation amongst different viruses. So particularly, but when the onset is with cold and sneezing, and symptoms are restricted to the upper airway like common cold, but mild or no fever, and the child is not exhausted and is quite playful, then one can suspect viruses like rhinovirus. Adenovirus is a different ball game where we can have pharyngoconjunctival fever, diarrhea, mesenteric lymphadenitis, hemorrhagic cystitis, and respiratory syncytial virus usually affects children under the age of 2, particularly under the age of 1 year, and presents with bronchiolitis. And COVID-19, we have witnessed coming with fever, dry cough, and to some extent, a change in the sensations of taste and the smell in older children. And the bacterial enemies like group A beta hemolytic streptococcus coming with fever, follicular tonsillitis, tender cervical nodes, pneumococcus coming with fever and grunting and tachypnea, and staphylococcus coming with rapid progression and a toxic look, and mycoplasma predominantly presenting with cough and affecting a bit older age group. So these clinical indicators could guide our colleagues to at least suspect that the given organism in front is of this particular category. So there is another child, 4-year-old with cough and fever of high grade since 5 days, and is not settling with oral medicines. On admission, has tachypnea and needs oxygen support. And this is the X-ray which shows lesions on the right side. And on investigation, the total count was 1620 and the platelet count of 132,000. SGPT and SGOT are raised, and nasopharyngeal aspirate is positive for H3N2. So this was influenza with low WBC count and low platelet count. So Dr. Anil, given this particular picture, how would you rather analyze this particular case?
Right, sir. If this child is presenting to us in this epidemic and has a classical acute febrile illness with a respiratory illness and not settling with oral medications, probably somebody would have started on oral antibiotics and still has progressed to the extent that the child has had now red flag signs and ended up getting admitted into the hospital requiring oxygen also. This is straight away category C. And with this ongoing epidemic and the respiratory involvement, and the labs are also supporting of a viral etiology here. Total counts are low with the platelets are also trending on the lesser side. Multi-system involvement with little bit of transaminitis happening. our first diagnosis, clinical suspicion is for a flu, and that is again well supported by the nasopharyngeal swab, which is positive for H3N2. At the same time, because just because it's an epidemic, we should not get fixated on to only flu-like illness. Also, because dengue, our old friend dengue, also we should always keep in mind. So definitely, this child is worth that we also screen for a coexisting co-infection with dengue and get a probably dengue ELISA test done also because of the transaminitis that is there, and the child is becoming more sicker. Of course, we go ahead and start them on empirical, or once the swab is positive, oseltamivir is the treatment of choice, but not to forget other tropical infections like dengue fever.
Yeah, and during this particular season, sometimes we do come across influenza co-infected, with dengue, sometimes influenza with RSV. Dr. Somshekhar, do you have any additional experience about such situations?
No, we do have coexisting dengue, and majority this time they are presenting with a mild form and have a high index of suspicion. Have a serial monitoring of the vitals and the platelet, more than enough. They are not complicating each other. They're relatively safe. But when you come to this picture, is a classical picture of any viral flu. And of course, in this season, as we had experiences with dengue, think of that also, because that will help with the monitoring and the management of the patient.
Sure, that's great. So now another question, Dr. Somshekhar, whether I think we have covered this question as to whether oseltamivir be started empirically or after investigations, but will you just try to repeat what we said earlier?
Ideally, better to do the investigation and start. But we said, as you said, you asked me a very important question in that two-tier cities or in the peripheral areas.
Yeah.
Yeah, high index of suspicion. If a patient is coming with some symptoms, progressing towards a complication, start that. Or the comorbid condition, immunocompromised state, or a chronic persistent asthma, or in diabetics, please give them. That's very clear. But when you have a facilities, do the investigation and start.
Right. This is another case. Again, 3-year-old child with cough and fever for 5 days. The fever was not settling. The counts were normal, and the investigations revealed H3N2. Another case where the counts were normal, but the CRP was on the higher side. You can also see the X-ray of this child, and the nasopharyngeal swab showed H3N2. Dr. Anil, could you just tell us as to what are the factors on which clinical response to oseltamivir depend?
Yes, sir. The most important factor is, did we start it at the right time? As soon as there is a clinical suspicion of a flu-like illness, so I think we should go ahead and start them on oseltamivir for the category B, that is a moderately sick to severely sick patients. We should start them pending the results, or even if we don't have the resources, we are not doing. I think in these situations where they're moderately sick to severely sick, like the X-ray what we saw previously, they deserve to be started on oseltamivir. So by starting it within the first 48 hours, we're going to limit the spread of the viruses and limit the progression of this or the complications we are going to limit. So that should be the most important. And for the severely sick ones, like what we are seeing right now, even though they are coming to us on day 4, day 5, for someone who has got a consolidation which is starting in the lung and a typical viral kind of illness, even they deserve to be started on oseltamivir, even on day 4 or day 5. That will limit the progression and also hasten the recovery process.
Yeah, that's great. This is a child which deceived us. He was 4-year-old with cough and cold for 5 days with high WBC count, high CRP of 136, and the high fever continued. And of course, the nasopharyngeal swab showed adenovirus positivity, and adenovirus has to be kept at the back of mind. Now, this is a 5-year-old girl with high fever for 5 days, cough and cold for 5 days, and she is sick looking with mild wheeze, but there are no crepitations. Dr. Somashekar, will you like to put this girl on antibiotics?
First 3 days, if you take a viral syndrome, it is the acute onset, rapid progression, or rapid deterioration. Here it is almost is running for 5 days, and associated cough cold and little sick also. No crepes, this worthwhile, but still have an index of suspicion of viral in this scenario. But it's worth starting the antibiotic.
Okay, so accordingly, this girl was put on amoxiclav, and the investigation showed that the WBC count was 2800 with neutrophils 10 and lymphocytes 70, and the CRP was 34.7. And Oseltamivir was also started, but the nasopharyngeal swab showed rhinovirus. Always there is a discussion about the sensitivity of influenza PCR and the treatment decisions. We have already discussed it. And Dr. Anil, just some additional point from you about the rhinovirus and some similar viruses which are not usually considered to be, very troublesome. So if you find such viruses, how would you look at
Yes,
that?
sir. This is a big child already into day 5 of illness. So rhinovirus alone probably may not produce such a kind of systemic symptoms that the child is becoming sick even after day 5 of illness, because rhinovirus usually it's a localized virus with a probably very very mild systemic illness. So probably this was just there as a commensal, or the swab has picked it up. Probably may not be of much significance over here in our treatment decisions. Like already we have started the child on coamoxiclav, the CRP is slightly elevated and the X-ray is kind of worsening. In this situation, probably we will continue with our clinical decision making and probably continue with the antibiotic at this point in time, not giving much importance to this rhinovirus in this particular situation. Had the same thing been there in a small baby, like less than in an infant, probably a rhinovirus which is coming, and probably we can think that it is because of rhinovirus, not in a big girl like this on day 5 who is already becoming sick.
Yeah. So there are some viruses like these which could be just the bystanders. And there is another girl who is a 7-year-old daughter of IT sector parents. And IT sector parents, as you know, in Bangalore as well as in Pune, they are always, very, very anxious. And I say that IT sector parents are not only the ones from information technology sector, but also inquisitive and to some extent troublesome. Though, of course, sometimes we do enjoy interacting with them because they are very intelligent. So this daughter has high fever for 3 days with throat irritation, and she has an exam 2 days later. The throat is showing mild congestion. She has been given paracetamol. The flu and the adenovirus are around. So how do I manage? That is the question when you are faced with such parents as regards the investigations, the throat swab, starting empiric Oseltamivir. So, Dr. Somshekhar, how would you manage this particular girl?
It's the common scenario that to know the midterm exams are going on. Everybody comes and asks this only. And we'll tell them you should wait for 3 days recovery. They'll ask for about antibiotics. But you stick on to your principle, tell them that I have given the medication. Usually it takes to 3 to 5 days. Within 3 days, because of the flu-like illness was going on, if she deteriorates, if we deteriorated or any other associated symptoms, we'll reconsider anything. Otherwise, your reassurance makes a big difference. Tell them because maybe exams are there. Doesn't mean that we should push the medications at this hour. But as Dr. Anil was telling, we give 2 minutes of extra makes a big difference.
Yeah, I agree with that. And we have already seen as to how long oseltamivir should be administered, and we said that it has to be given as a therapy for 5 days and for chemoprophylaxis for 10 days. Though we know that in the practice of adult medicine, sometimes depending on the situation, the adult physicians have been seen to prescribe larger dose for a longer period. Though as pediatricians, we will stick to 5 days for therapy and 10 days for chemoprophylaxis. Now, this is a 3-year-old boy with cough for a week, high fever for 3 days with crepitations, managed with coamoxiclav and admitted for persistent fever. He has been put on IV amoxiclav with WC count of 7,750, neutrophils 49, CRP of 2.8. The swab was influenza A positive, and oseltamivir was added depending on the swab report. So the question here, Dr. Anil, is already a child who has been on an antibiotic and now turns out to be positive for influenza A, whether we should stop the antibiotic and how to take a decision about continuation of antibiotics in presence of a positive swab report for influenza.
Yes, sir. In such a situation, we have a swab report which is already positive. And we have the labs also which are backing us. Total counts are 7,000, CRP is negative. I think with all confidence, we should be able to stop the IV antibiotic because we have demonstrated a clinical syndrome, acute febrile respiratory illness with a severe myalgia, body pain, sore throat, and going on to a respiratory thing and middle of an epidemic. And I think with all confidence, we can go ahead and stop the antibiotic in such a scenario.
Very good. So this is something related to rational antibiotic therapy, and that's why the answer to this question as to whether we prescribe antibiotics concurrently is, something which our colleagues must remember, that it all depends on the presenting features and the lab reports and the supporting lab reports and the progression of the illness. But as far as possible, you have to try to be rational depending on the clinical scenario. And this is a part of the antibiotic stewardship. So if the reports are, PCR positive, so either you do not give antibiotics, you stop ones which are there, or you do not at least escalate the ones. So you have to take a very, very rational decision.
So
Now there is another case. Yeah, please. Yes.
if you
Yes, doctor.
find any localized symptoms, like
Yeah.
crepitation or in X-ray, there's a packet or anything, or any ear discharge, then you can give. Otherwise, as Anil said, it's a right away case, stop the antibiotic.
Yeah, sure. Of course, as we all know, sometimes in children who have adenovirus, many times we get a presentation like, high WBC count, high CRP, some lobar consolidation. Many times we are deceived, but it all depends on the clinical and radiological presentations. There is another case, where 11-year-old boy came for fever, vomiting, cough, and altered sensorium for a day, and was thought to be having encephalitis. The X-ray chest showed haziness on the right lung, and the child was intubated in the emergency room and shifted to the PICU. The lumbar puncture was done when CSF was normal. He was put on IV antibiotics after stenting the blood culture, IV antiviral and other symptomatic treatment, and the nasopharyngeal multiplex PCR detected influenza A, H3N2, and the CSF meningitis panel was negative. This was the X-ray of this particular child. The neurologist reviewed the child and opined as viral encephalitis. He continued to have fever spikes. And then on day 2, the child had low urine output. The lab showed creatinine 2.24, and pediatric nephrologist reviewed the child and opined as acute kidney injury. And it was KDIGO stage 3, advised to stop IV cyclovir and to USG abdomen plus pelvis. Basically, this USG reported mild splenomegaly, both kidney showing raised cortical echogenicity. The EEG, which was done, reportedly normal. MRI brain on admission was also normal. And on day 4, he was noted to have haziness in the right upper lobe and paracardiac shadows suggestive of aspiration pneumonia, for which he was given prone ventilation, chest physiotherapy, and IV antibiotics. Dr. Anil, now that you are in the ICU, I would just like you to tell our colleagues a bit about, the complications of this particular disease in brief.
So the most important complications we are seeing is the respiratory, where they have respiratory distress. Thankfully, this season, majority of them are improving with just routine care, supportive care, oxygen, nebulizations, they're improving. Few of
Right.
them are going on to develop severe ARDS requiring ventilation, supportive care. And very few of them, like Sir told, multi-system involvement where they're requiring renal support as well as the CNS complications of it, febrile seizures, febrile encephalopathy, acute necrotizing encephalitis also we have seen. So
Right.
these are all the different complications we are seeing. And I think again wants to reiterate that whenever there is a suspicion of a flu-like illness in the midst of an epidemic, we need to start early, empiric also at some point in time if they're getting sick, moderately to severely sick, to avoid all these complications. The Oseltamivir is of great help, starting them in influenza-like illness with moderate to severely sick patients. We need to start it much early to avoid all these other multisystemic complications.
Right. So influenza is known to have so many complications. Just some of these cases where we had influenza H3N2 along with RSV, and basically there are certain cases where we had to be very, very careful. As regards the respiratory complications, just to recapitulate, it's possible that the child gets otitis media or pneumonia, which is primary viral pneumonia, or co-infection with Streptococcus pneumoniae or Staphylococcus aureus, and pneumonia is in 50% cases interstitial, 25% alveolar, and 25% both. Exacerbation of chronic pulmonary conditions like asthma also can occur, particularly beyond 2 years, and respiratory failure in a few patients, and acute laryngotracheobronchitis. So this was a child who was a 6-year-old child with cough, cold, and fever, with respiratory distress and cardiac, hepatic, and lung involvement. Rapidly progressed, and he was on HFOV. And this was this particular child who turned out to be positive for influenza B, along with strep pneumoniae and also Haemophilus influenzae. We have many, many complications like toxic shock syndrome, rarely, cardiac problems like myocarditis. And you must have seen children with myositis, particularly this is common with influenza B, where they get bilateral gastrocnemius and soleus involvement, presenting with severe bilateral calf muscle pain and inability to walk. And we have also discussed about the Rye syndrome after exposure to salicylates in children with influenza B. We will have just quick rapid fire to both my colleagues. So, Dr. Somshekhar, we have already discussed this point. Maybe you can just repeat it. If a child gets admitted on day 4 of the illness for lower respiratory infection and comes influenza A positive, shall we start Oseltamivir, and up to what day of illness it will be effective?
Ideally, better to start on the second or third day. But here is an ongoing condition, give a dose of benefit. Fourth or fifth day, please give the dose of benefit.
Very good. Dr. Anil, the elder sibling of an 8-month-old child is admitted with influenza A for LRTI, and this 8-month child develops fever. Shall we start Oseltamivir?
Yes, sir, because already there is a proven case in the family, and children has been no less than 2 years of age comes in the high risk category group. So this 8-month-old child, when it starts developing fever, we should go ahead and start the child on Oseltamivir, 3 mg per kg, twice a day for 5 days.
Right. Dr. Somshekhar, what is to be done if a child is not accepting oral medicines? Whether there is any other alternative for Oseltamivir?
No alternative. Good thing we have oral medication.
Okay. So,
We can try at least. Yeah. We can repeat the dose. Not unlike injectables. We
Sure.
should try. For
Right.
some bitterness and vomiting, all those things will be there. Try with that small frequent feeds and all.
Okay. Dr. Anil, shall we give chemoprophylaxis to all the household contacts of a child who has proved H1N1 or H3N2 positive?
A small correction, we should give this to all household contacts at high risk, not for all household contacts. For a healthy adult may not really require a chemoprophylaxis, but anyone who is diabetic, obese, immunosuppressed, undergoing a cancer chemotherapy for whatever reason, chronic heart disease, liver disease, or extremes of age, who is anybody who is age more than 65 having a heart condition or very small in babies, yes, we do extend them chemoprophylaxis.
Right, very good. So our colleagues who are listening to this program, maybe they can develop a habit of asking the history whether there is anyone in the family who has such high risk condition, so that in addition to this child, you can also think of giving medication to the high risk contacts. Dr. Somshekhar, is this high grade fever, severe sore throat with cough and cold, whether it's an indication for starting Oseltamivir in current situation to all those coming to the OPD?
No, not required. Because we said already, we discussed a lot of other conditions are also there, including bacterial. So there's no point in giving.
Right. Yeah. And resort to the categorization of B and C and then decide. And Dr. Anil, the last question is whether this oseltamivir works on this para-influenza viruses.
No, sir, it doesn't work on para-influenza viruses. So oseltamivir here is not indicated. The clinical phenotype we get here is the small babies who have a croupy kind of a cough with a little bit of respiratory distress. These are the ones who are turning out to be para-influenza positive, and there is no role of oseltamivir in such cases.
Right, very good. So we can all understand that influenza is a fast and a furious virus with abrupt onset. high transmissibility, rapid progression, likelihood of progression to complications like ARDS, and may, particularly have high mortality, and you have to administer oseltamivir very, very quickly. So with that, in addition to the early treatment, we have to be also careful about some precautions related to our hand. I always say this is Hasta Pancha Sutri, 5 things related to the hand, like hand washing, avoiding handshake, using handkerchief, keeping other people at a hand's distance, and avoiding hand touching. These are important precautionary measures. And in addition, we have the flu vaccine. So just as when we say happy birthday to you, we should always remember there is something like happy birthday to flu. So on the day of birthday, we can always administer flu vaccine because it's a once in a year affair. So with that, I thank all our listeners and thank my panelists for this particular interaction. And with that, I say namaste and not a shake hand. So let us follow our typical Indian tradition of namaste. Thank you very much.
Thank you, sir. Namaste.
The questions
Thank
are
you very much.
there,
Sir, there have been a couple of questions from the audience. I'll just
Very
read
good.
them. One is,
Okay.
what are the major genetic differences between influenza A, B, and C virus, and how do they affect disease severity?
Actually, influenza A, B, and C are definitely different. The point is that H and N, these are the two important glycoproteins, and they are basically the amino acid sequences which differ. Okay, there is no point in knowing exactly which amino acid is different, but what one should remember is that whenever the virus changes its structure every year, the amino acid sequence changes, okay, and that leads to the drift. Okay, so if Ramesh becomes Suresh, okay, then it becomes a drift. Okay, but it suddenly Ramesh becomes Anil, then it is a shift. It's a major change. Okay, where there is a tremendous change which occurs, and this particular shift occurs particularly in influenza A viruses, where animals like pigs and others, they act as mixing vessels. So some virus comes from the bird, some from the human beings, and both these viruses, they mix up, like something like a bhel, with the murmura and dal, everything in one pot. So there is a lot of mixing, and finally the output is like some new kind of a virus which the world had never experienced, against which the world never had any immunity. And that is exactly what happens when there is a pandemic. Okay, so this is enough for our audience to know, though exact changes in the amino acid sequence, they vary every year, and there is no reason for us to remember that. Thank you.
Thanks, sir. There's one more. As per government,
more
Yeah,
of
yeah,
specific.
yeah.
And that's said, A is more of it is in the animals also. It is in pandemic, but B as such is more of human specific, more
Yeah,
of
yeah.
related epidemic. Another question is there.
yes, sir. As per government, from doctor, as per government, oseltamivir is prohibited for sale and prescriber. Is it correct?
That you should answer.
No, sir. I think it's freely available. I think in the earlier 2009 pandemic, when there was a shortage, it was made mandatory that we have a triplicate of our prescription where the pharmacist would stock one just to avoid black marketing and all these things. But now I think it is freely available across the market. It can be freely sourced upon the prescription. They can be obtained from the pharmacies.
Thank you so much, sir. Thanks. Thanks, Dr. Pramod. Thanks, Dr. Somashekar. Thanks, Dr. Anil. It was always a pleasure, joining your webinar. Sir, thanks once again. Thanks, Nagadevi. Thanks, Samriddhi. And thanks all the doctors who took time from the schedule and attended this meeting. Thank you, thank you, IT team, and thanks, field people. Thanks once again. We can sign off, sir. Thank you.
Thank you, sir. Thank you. Thank you, sir.
Thank you.
Sir, I would like.
Question.
Yeah.
So I would like to add in the question what was asked, like Oseltamivir being prohibited for sale. So earlier it was in Schedule M and now it is in Schedule H.